Check one. Hello.
Check 1 2. Check. Check.
Good morning, ladies and gentlemen, distinguished guests, and the audience present here in the auditorium. This is Dr. Shamshad Rabbani Khan, the graduate of the Field Epidemiology Training Program, Bangladesh. I'm welcoming you all to the opening day of the first Bangladesh Congress on Epidemiology and Public Health, jointly organized by the Field Epidemiology Training Program, Bangladesh, run by Institute of Epidemiology, Disease Control and Research, and the Epidemiological Association of Bangladesh, EPUB. Today, in this introductory session, the guest of honor present among us, Professor Dr. Mirzadi Sabrina Flora, Honorable Additional Director General, Planning and Development, Director General of Health Services, and General Secretary, EPUB, Bangladesh. Professor Dr. Tahmina Shirin, Director, IEDCR, Dr. Michael Fredman, Bangladesh Country Director for the U.S. Center for Disease Control and Prevention, Atlanta. Dear audience, our sincere gratitude to Dr. Carl Reddy, Director TEFINET, for his recorded message, and Dr. Alden Henderson, epidemiologist and advisor of the US CDC, who also joined remotely from USA. Welcome, Dr. Henderson. We would like to thank all our guests for their precious time. Your presence will definitely inspire all of us to proceed further. Distinguished ladies and gentlemen, the objective of the first Bangladesh Congress of Epidemiology and Public Health are to showcase the public health research and epidemiological approaches to identify the public health priorities in low and middle income countries, to encourage more rigorous scientific assessment and studies to strengthen capacities to respond in public health emergencies, and to increase the visibility of field epidemiology training program field experiences as well as the work of other public health professionals globally, and to bring to the forefront work, achievements, and research they have conducted on COVID-19. This platform will enable epidemiologists, young researchers, public health professionals, and field epidemiologists from Bangladesh and other countries to share their experiences in the field of public health. Moreover, this conference will provide a unique opportunity for the fellows and graduates of the FETP Bangladesh to share their fieldwork with the national and international public health community. It will also create a global network for public health experts in preventing future pandemics. Dear audience, the event is supported by the Training Program in Epidemiology and Public Health Intervention Network, or TEFINET, and Center for Disease Control and Prevention, Atlanta, USA, popularly known as USCDC. For this Congress, we received more than 120 abstracts all around the world. The thematic area for our abstract included emerging and re-emerging diseases, disease surveillance and emergency response, COVID-19 pandemic and the role of field epidemiology, non-communicable diseases, immunization, and One Health. We would like to thank all the participants who submitted their abstracts for this event. In this next 2 days, we have oral and poster presentations, plenary sessions, and roundtable discussions. We would like to request all the participants for their active participations in all the sessions. Dear audience, all the posters are open to our website, so if anyone wants to see the posters during the session, they can go to the website and see them by clicking the individual link. Moreover, we have also Facebook and YouTube live streaming going on. So in the website, you can go there and you can find the link to enter to the YouTube and Facebook link. Dear audience, now it's time to listen from our distinguished guests. To begin with, I would like to start with Dr. Alden, who is a public health epidemiologist and advisor from US CDC. Dr. Alden has been supporting the Field Epidemiology Training Program Bangladesh from the very beginning. With his mentorship and guidance, FETP Bangladesh is successfully moving forward. This is my honor to welcome Dr. Alden Henderson as the first speaker of the Congress. Dear audience, Dr. Alden Henderson.
just getting us all together, to me, is a success. And for you, for this conference, I have two requests. First of all, to be flexible. Holding the conference of a pandemic is very challenging. Speakers and presenters may be absent because of COVID and present problems, so please be patient. Second ask is to enjoy this moment when we can share the science, the friendship, and your accomplishments. Then finally, after all the counting and comparing, you will have a chance to communicate your findings. And I wish to be there to enjoy this moment.
No, দরকার নেই দরকার নেই এইটা
Thank you.
এটা চালাবে
Thank you, Alden, for your nice and short speech. Definitely, your wish and all your guidance will lead the FETP Bangladesh to move forward again. So I have Dr. Farzana with me. Dr. Farzana, can you introduce yourself and continue the session?
Thank you, Dr. Rabbani. I'm Dr. Farzana, a graduate from the 4th cohort of Field Epidemiology Training Program, Bangladesh. I'm currently working as a medical officer in IDCR. Training programs in Epidemiology and Public Health Intervention Network, or TEFINET, is the global network of 75 field epidemiology training programs working with a mission to strengthen public health systems across the world. TEFINET has supported the Field Epidemiology Training Program Bangladesh since 2013. Now we'd like to hear from the director of TEFINET, Dr. Carl Reddy, on this very first Public Health Congress in Bangladesh. He was kind enough to send us a video message. May I kindly request the IT team to play the message for us.
TEFINET wishes the FETP Bangladesh every success on hosting its first Bangladesh Congress on Epidemiology and Public Health from March 31st to April 1st, 2021. This is indeed a feather in the cap of the FETP Bangladesh, and there is no doubt in my mind that this will become a signature annual event. Since the establishment of the FETP Bangladesh Advanced Level in 2013, roughly 8 years ago, the FETP Bangladesh has dedicated itself to building field epidemiology capacity. This resulted in the establishment of the frontline level a short 3 years later in 2016, and the intermediate level which will start this year. It is worth mentioning that a member of the first cohort was able to lead the frontline. In fact, the praises of the FETP Bangladesh were sung to me many years ago by none other than Steve Luby and Dorothy Southern of the Pathway to Publishing fame. I hope that rings a bell. TEFINET is proud of the achievements of the FETP Bangladesh, including the sterling work that fellows and graduates of the advanced and frontline levels did in response to the COVID-19 pandemic. This included the development of guidelines, regular press releases, and IEC guidelines, event-based surveillance, follow-up of passengers coming to Bangladesh, quarantine activities, the investigation of over 6,000 COVID-19 cases and contacts, training over 2,700 healthcare workers on case investigation and contact tracing, amongst others. FETP Bangladesh even won the TEFINET COVID-19 response video contest. All of this is indeed testimony to the return on investment that funding committed to FET Bangladesh's growth and development has brought. The truth is that FETP Bangladesh is an inspiration for strengthening public health systems and advancing health security in a country beset with many health challenges. And TEFINET looks forward to strengthening its long-standing partnership with the FETP Bangladesh and wishes it well over the next few days on hosting its first conference. Thank you. Thank you.
We thank Dr. Carl Reddy for his speech. The US CDC works to protect health and fight disease around the globe. It is playing a significant role to build strong capacities and skilled leaders in public health in Bangladesh by running the Field Epidemiology Training Program with IEDCR. Now we request Dr. Michael S. Friedman, Country Director for US CDC in Bangladesh, to deliver his welcome speech for the audience.
Hear me okay? I want to start with a thank you to our CDC partners, the Epidemiology Association of Bangladesh, IEDCR, DGHS, and to our CDC team of consultants and staff for their support, their efforts, and their collaboration to make this important conference happen. I want to especially thank Professor Flora and Professor Tamina for their leadership in the field of epidemiology and public health. And I also want to especially thank Dr. Masoom and Dr. Zaki for their day-to-day leadership of this event and their tireless efforts to ensure all aspects of this large conference were organized and prepared. Thank you all. I stated that this conference is very important. Why? Why is it so important? First of all, public health needs more attention and a higher priority in Bangladesh. The health of a nation does not develop only through clinical services. That is treatment of disease and is not really what we mean by health. I would argue that the great improvements in Bangladesh, in health improvements in Bangladesh over the past 50 years are mostly due to improvements in public health and social determinants of health. Global primary education, for example, has been the biggest driver of health improvements and reduced infant and child mortality in the world. This is very much. Hello? Can you still hear me?
Yes, Alan. Yes, Alan.
All right, there was a little bit. Okay, anyway, this is very much likely the case in Bangladesh, but expansion of family planning, immunization services, food security, and safe water all play big roles as well. These are all public health interventions and things that epidemiologists study and care deeply about. Secondly, going forward, public health and epidemiology have lots more to do in Bangladesh and globally. Of course, we have a pandemic to tackle and current and future outbreaks to address, and unfortunately, future pandemics to prepare for. We also have a number of emerging health issues to understand and address. We'll hear today at this conference and tomorrow a few of these things. The biggest to me are mental health, uncontrolled hypertension, air pollution, injuries, and healthier lifestyles. This is a big change from our infectious disease focus, and that change in mindset should begin here at this conference. Epidemiologists are vital to public health, number 3, and we need to recognize them and advocate for their placement throughout all districts and cities in Bangladesh and their career advancement in the health system. You want your future leaders to think like an epidemiologist and public health expert. We need leaders who see things from a population and community perspective and understand the science of epidemiology and public health. The COVID pandemic and the current wave of new cases is a perfect example of this. Proper disease control action first takes proper understanding of both the disease and the behaviors and fears of the people themselves. I will end this by making one last point. Epidemiologists and public health leaders are only as good as their ability to communicate the science, their findings, and their recommendations. The pandemic globally is a great case study on this. Where do you get your opinions and understanding of this pandemic from? Has information been clear, accurate, and trustworthy? Think about this conference as an opportunity to improve each of our communication skills, not just what we say during a presentation, but also what questions are asked and how we answer these questions. So enjoy the next 2 days, and I hope at the end we learn a bit more about the issues Bangladesh faces and the exciting field of epidemiology. Thank you.
Thank you, Dr. Michael. Institute of Epidemiology, Disease Control and Research, or IEDCR, is the institute that is mandated for outbreak response in Bangladesh. And as a result, this institution has played the first and foremost role and continues to play a very significant role in fighting the ongoing pandemic of COVID-19 in Bangladesh. Now we request Professor Dr. Tahmina Shirin, the Director, IEDCR, to deliver the welcome speech for the audience.
Good morning to Dr. Alden, Dr. Reddy, Dr. Michael Friedman, and Professor Dr. Mizadi Sabrina Flora, and all other guests and audience who present online and offline in first Bangladesh Congress of Epidemiology and Public Health, which is jointly organized by AFPPB and Epidemiology Association of Bangladesh. Now, this is a critical time in COVID-19 pandemic, and we realize the need for exchange of scientific knowledges and experience even more during these days. I congratulate the organizers for their timely initiatives and tremendous effort to make it happen, and wish that this Congress will be a successful platform for the national and global public health experts during these pandemic days. I hope the epidemiologists, young researchers, and public health professionals from Bangladesh and different parts of the world who are participating in the conference will use this platform to share their knowledge and experience in the field of public health, especially related to preparedness and approaches to fight against the ongoing COVID pandemic. Last but not the least, I strongly suggest everyone home and abroad to strictly follow all the preventive measures for the COVID-19 situation and ensure safety for all others. And I think that you will enjoy these 2 days, and I would like to stop here. Thank you. Thank you all.
Thank you, Madam. Now, as the final speaker of this welcome session, we'd like to request Professor Mirjadi Sabrina Flora, ADG DGHS, one of the pioneers confronting COVID-19 pandemic in Bangladesh, who played the vital role as the then director of IEDCR during the emergence of COVID-19 pandemic in Bangladesh, and is continuing to undertake the challenge to fight the pandemic from the DGHS Bangladesh.
শোনা যাচ্ছে না কিছু?
ম্যাডাম, এখন শোনা যাচ্ছে? Madam, can you hear
Madam,
us
can you
now?
hear us now?
I can hear you now, but nobody could hear what you said before. I think it is
Sorry,
good to-
audience, I'm repeating. Now, as the final speaker of this welcome session, we'd like to request Professor Dr. Mirjadi Sabrina Flora, ADG Planning DGHS, one of the pioneers confronting COVID-19 pandemic in Bangladesh, who played the vital role as the then director of IDCR during the emergence of COVID-19 pandemic in Bangladesh, and is continuing to undertake the challenge to fight the pandemic from the DGHS Bangladesh. Dear audience, now we'd like to hear from Professor Dr. Mirjadi Sabrina Flora.
Thank you, Dr. Farzana and Dr. Rabbani. All the participants of this very important Congress, the first Congress on Epidemiology and Public Health, along with the speakers of this session, Dr. Alden, Dr. Michael, Professor Kahina Shirin, and also to Dr. Karl Reddy, whose recorded message we heard. I like to start my conversation. It's better to say it's kind of conversation. It's not a speech. Congratulating the team who have organized this important conference, the very first Congress on epidemiology during this pandemic situation. It's really hard to organize this kind of conferences within this scenario. It's really very, very difficult. And you took that challenge. I like to congratulate you all. Just to say a few words, most of the things are being already told, as Dr. Michael and Dr. Alden also highlighted the importance of these kind of conferences, and also Professor Kahina Shirin elaborated. So I would focus on the importance of epidemiology perceived by the general people or perceived by the policymakers. I think before this pandemic, epidemiology was not that much felt subject by the policymakers, which has become obvious during this pandemic situation. Everybody understands the importance of epidemiology, and with this backdrop, I think this Congress carries additional value. So I have one request to the organizers to compile all the results of this conference, which will be presented here, all the study findings, along with the take-home message for the policymakers, or the evidences which we can take to incorporate in our policy in order to contain or prevent pandemic as well as our endemic diseases. When we worked with this COVID-19 pandemic, we realized the importance of cost-effective approaches. We had a lot of pressures to do a lot of things, but as Epidemiology Institute, IDCR had to decide on the which is most cost-effective and which is very important for a resource-limited country like Bangladesh and others. And this pandemic actually is not, we all know that, is not easy to contain. And Bangladesh was successful in containing as well as starting the vaccination program. Unfortunately, for this month, we are observing upsurge of diseases, and it's very rapidly growing. So the need of epidemiologists, again, is very crucial. The involvement of the epidemiologists is very crucial. Whenever we decided to take decision about which diagnostic should be tested, which methods should be used for diagnosis or detection of cases, which treatment should be considered, when the vaccination should be stopped, when vaccination the second dose should be given, everything we depended on the data. And in many areas, our epidemiologists played a significant role in taking these kind of decisions. And also currently, our epidemiology team is working to identify the containment measures, the public health measures, which measures should get more importance, which area should get more importance in containing this upsurge of cases? Again, epidemiology is very important. So I'm kind of trying to show all the participants the importance of epidemiology. And this is not only for the pandemic situation. As Dr. Michael also mentioned about non-communicable disease, mental health, and other issues. And I'm very happy to see the list of the abstracts you have submitted to this in this conference, which covers every area of public health importance, and also every area which brings epidemiological significance. It includes not only communicable disease, it includes non-communicable disease. It includes not only the outbreak-prone diseases, it also included long-term endemic infectious diseases. It has included other areas of public health which are more important, like environmental issues and others. It included not only COVID, it includes as TB as well as TB. I'm mentioning tuberculosis because it's one of the oldest disease. So newest addition to oldest kind of diseases, every diseases are being will be presented here by the participants, and we'll learn a lot of things about the recent advancement in these areas. This conference would be a kind of hybrid design, what I understood, like it will have physical presence, and it includes the Zoom or online opportunity also. Who couldn't attend physically, we try to connect them through this Zoom link. And as well as it will help us in containing the pandemic, or in containing, or in preventing, or in fulfilling the public health measures to prevent the upsurge of COVID-19. We expected many of important guests as we decided to hold it on these 2 days. At that time, COVID was actually very controlled phase. So, but suddenly, unfortunately, we are having a higher number of cases now. So we had to redesign. We had to minimize the physical presence of our participants. So for that reason, we couldn't invite many of the persons whom we plan to include. I apologize for that because we have to be very selective to minimize the number of participants to be physically present. And I would stop here because I will be with you hopefully for whole 2 days now and then. I'm not sure how long I could be, but I would be happy to take part, and I would be very happy to take part, not only take part, to participate in every discussion if everything goes well. And I would be happy to have conversation with every participant if I get opportunity to have to learn about your ideas, to learn about your innovations, that we should help our Director General's office to develop the next plans, to develop next policies. That would be really evidence-based policy. I thank the organizers for inviting me. I am expressing my gratitude on behalf of Director General's Office as well as Epidemiological Association of Bangladesh for taking EPAB in this important conference as co-partner. Although most of the tasks are done mostly by the Field Epidemiology Training Program fellows and the graduates, but our resources from Epidemiological Association also try to take part, try to help you in organizing that workshop, this conference. I would stop here and thank you very much. And I would end my this small speech reiterating what Professor Tahmina said. Please follow all the public health measures to prevent this current upsurge of COVID-19 in Bangladesh. Thank you very much. Thank you all.
Thank you very much, Madam. Professor Mirzadi Sabrina Flora, ADG, Planning and Development from the Director General of Health's Office, Bangladesh. Madam, your guidance and inspirational speech will definitely help us all in the way forward. Now, I have a small request to all the audience present here in this venue. Please mute your microphones in the Zoom link, and also please do turn your volume of the devices a little low. Thank you. Now we would conclude our welcome session and move to the next session. We'd like to introduce Dr. A.S.M. Alamgir, who is a physician who also did his PhD and postdoc fellowship in molecular biology. He is the author and co-author of a number of peer-reviewed journals. From the very beginning of COVID-19, he has been playing a significant role in mitigating the COVID-19 in Bangladesh. Now we'd like to hand over the session of Scientific Session 1, that is a session of oral presentation, to Dr. A.S.M. Alamgir to moderate the session.
Good morning, everyone, and welcome to the first scientific session of First Bangladesh Congress on Epidemiology and Public Health. And so those who are on the online in different platforms, social media, so we are very sorry that we cannot meet in person with everyone. I know many of you joining on online. So we'll start our session, and we had a very different experience, and we are experiencing the COVID-19 in our country, and IDCR and the APTP fellows, they played a very vital role during this pandemic. And you know that we had the first experiences of institutional quarantine in this country during this session. And so I would like to invite Dr. Major Jinnatun Nobi. His presentation title is Successful Quarantine of Wuhan Returned Passengers in Dhaka on February 2020. Dr. Jinnatun Nobi.
Thank you, Mr. Moderator, for giving me the opportunity. Assalamu alaikum, and a very good morning to you all. I am Major Dr. Jinnatun Nobi, a fellow of Field Epidemiology Training Program, Bangladesh. Sorry for the inconvenience. I am Major Dr. Jinnatun Nobi, a fellow of Field Epidemiology Training Program, Bangladesh. Welcome you all to my presentation on successful quarantine of Wuhan returned passengers in Dhaka, February 2020. On 31st December 2019, a cluster of pneumonia patients was reported for the first time in Wuhan, China. Later on, it was identified as novel coronavirus, which was named as COVID-19 after that. Wuhan was under the lockdown on 23rd January 2020, which was the first lockdown for COVID-19 in the world. On 30th January 2020, government of Bangladesh decided to bring back the Bangladeshi citizens who was in Wuhan. On 31 January 2020, a special flight of Beyond Bangladesh Airlines was sent to bring those citizens back. On 1st February 2020, the flight arrived with 307 passengers at Hazrat Shahjalal International Airport, Dhaka. The objectives of my study was to find out the epidemiological characteristics of the quarantined passengers and to know the living conditions of the quarantined passengers. Now, methods of my study. My study was a descriptive type of study. The place was Ashkona Hajj camp, which you can see in the picture. My study time was from 1st February to 15th February. Here is a picture of preparation for receiving of Wuhan returned passengers. They were taken by buses from airport to the quarantine center, which was in Ashkona Hajj camp. The plane and buses were disinfected afterwards. The citizens were quarantined there from 1st February 2020 to 15th February 2020. Here is the activities picture where you can see the persons receiving the Wuhan returned passengers in the Ashkona Hajj camp. We screened the passengers on arrival for any kind of COVID-like symptoms like fever, cough, or respiratory distress. We also followed up the quarantined passengers for the whole period. If any symptoms developed, we took the sample for testing. The temporarily arranged quarantine center was a 5-story building. The passengers were kept in the top 2 floors. There are 8 rooms in those 2 floors. Each room had capacity of 50 people with 1 meter distance between 2 beds. Passengers had a common bathroom facility. The passengers were provided with foods, drugs, television, Wi-Fi, washing machine, hand wash, personal protective equipment. The whole quarantine process was managed in collaboration with Ministry of Health and Family Welfare, Ministry of Religious Affairs, Ministry of Disaster Management and Relief, Ministry of Home Affairs, and Ministry of Defense. Now, the results section. Among the 307 passengers, there are 263 persons were male, which was the 86% of the total number, and the rest 44, which was 14%, were female. This table shows that 171 persons was between the age of 21 to 30 years, which was 60% of the total respondent passengers. We also can see the second highest was 53% from 11 to 20 years, and 42% from 31 to 40 years. In this table, we can see the professions of the Wuhan returned passengers. Here, 262 persons, which was about 85%, were student or research fellows. We screened the passengers and we found that there are 10 persons having comorbidities like diabetes mellitus, hypertension, asthma, and rheumatic fever. Rest 297 persons was without any comorbidities. As I mentioned earlier, we screened the passengers on arrival. During the screening time, 5 passengers had COVID-like symptoms. During our follow-up in the quarantine period, 18 people, which was about 6% of the total number, developed COVID-like symptoms like fever, cough, respiratory distress. All were tested immediately after developing of symptoms. We found all of them were negative, and they were released with others after 14 days of quarantine period. In my limitation, as the quarantine center was selected as emergency basis, we could not give them proper quarantine environment. We could not quarantine them individually or in small groups. We also could not stop their free mixing due to the common bathroom facilities. In conclusion, we can say that though it was an emergency basis quarantine center, Bangladesh could arrange the quarantine facility successfully first time for a large amount of people. This success gives our government the confidence to maintain the quarantine center and quarantine process throughout the pandemic. Our recommendation is to establish a permanent quarantine center consists of small rooms with separate bathroom facilities to contain future outbreak. I want to thank the ministries who managed the quarantine process, Ministry of Health and Family Welfare, Ministry of Religious Affairs, Ministry of Disaster Management and Relief, Ministry of Home Affairs, and Ministry of Defense for my study. That's all for my presentation. Thank you all for your patience hearing. Now, I'm handing over to the moderator. Thank you all.
Thank you, Dr. Nobi, for your nice presentation. So now we have 5 minutes for question answer session. And if anybody have any questions from here, please you can ask or by Zoom, or I have few questions with me in the Google Sheet. So most of the things is like I know you know about those people who are involved in the quarantine, they knows, but this is one of the question is what are the actions taken and when an individual developed symptoms?
Thank you for the question. The actions were taken, we affiliated with Combined Military Hospital Dhaka and Kumudura General Hospital. 2 hospitals were affiliated with us, and if any patients develop any kind of symptom, we immediately isolate him to the hospital, and we isolated him until his reports came back. When he was found negative, then we again joined him with the others. Thank you.
So another question was is like, did you follow up the passengers after releasing with them from the quarantine centers?
Sorry, again, please, sir.
Did you follow up the passengers after completion of the quarantine period?
No, as we quarantined them for 2 weeks, after the completion of the quarantine, we didn't follow them up.
And one of the recommendation you said about the small rooms to quarantine, is it room for every individual or for a small group? Why do you recommend it? I guess I can add is like, so probably you are talking about the attached bathroom, not the individual group bathroom. So we had this problem during the quarantine, we know, but because that was a temporary lay, it was made for other services like for Hajj and other services. But for the quarantine people, I know and we all know that we need the individual quarantine room. But that was a temporary arrangement and emergency arrangement, right. So it was not possible at that time. Probably we'll recommend it to the government. And so anyone have any questions from here? So Faisal.
Yeah. Thank you for your nice presentation. I am Dr. Faisal Talukdar. I am a 3rd cohort fellow in FETPB. So in your presentation, you showed that during screening time, 5 person you think that there is a symptom like which is suspected, maybe suspected case definition. So have you any number that how many male and female are affected or show symptom in that period of time?
Yeah, in the screening period, there are 3 male and 2 females. And about the among the 3 males, 1 were children, 3 were from the same family, husband, wife, and the children. And when we found that they have symptom, we immediately isolated them to Kumutula General Hospital. But after we found them, they are tested negative, we then rejoined him.
Thank you.
Thank you.
Yeah, thank you, Dr. Novi, for your presentations, and thank you all for patient hearing. Now we have another so we don't have much time.
Many thanks to bringing out the historic action taken by the public health system of Bangladesh. One information I want to add, the Wuhan returnees was followed up for 14 days even after the release, and they were found, everybody, no case of, we could not found no case of COVID-19 among them. Personally, Director IDCR and the team, they followed up for 14 days further. You can add it.
Thank you for the information, sir.
Thank you. Welcome.
Thank you, Dr. Mustak, and so thank you, Dr. Novi. So we're going to the next presentation, and so I would like to remind you that presentations time is like 10 minutes and question answer session is 5 minutes. So now I'd like to invite the Lieutenant Colonel Dr. Isam Nurul Irfan. He's a frontline fellow and currently working as a fleet medical officer, Bangladesh Navy. And his presentation title is Epidemiological and Clinical Characteristics of COVID-19 Cases Attended in a Tertiary Hospital in Bangladesh. Dr. Irfan.
Bismillahirrahmanirrahim. Respected moderator and valued audience, Assalamu alaikum and very good morning. At the outset, I would like to convey my profound regards and gratitude to the organizer to give me the opportunity to be present here in this August gathering. And I'm starting with my presentation. My presentation is on epidemiological and clinical characteristics of COVID-19 cases attended in a tertiary hospital in Bangladesh. Sir, all of us know that in December 2019, a series of pneumonia cases of unknown causes emerged in Wuhan, Hubei, China, which later on initiates one of the most serious public health crises in the history of humankind. The unprecedented global pandemic that swept the planet is caused by the severe acute respiratory syndrome coronavirus 2, that is SARS-CoV-2 infection, termed by the World Health Organization as coronavirus disease or COVID-19. The virus was confirmed to have spread to Bangladesh in March 2020. The first 3 known cases were reported on 8 March 2020 by the country's Epidemiology Institute, IEDCR. Since then, the pandemic has spread day by day over the whole nation, and the number of affected people has been increasing exponentially. Until now, Bangladesh has reported at that time 2,79,000 plus confirmed cases, among which 1,60,000 plus were recovered and 3,600 died. As a part of the total community, members of Bangladesh Armed Forces also suffers from this disease. On 6th April 2020, Army revealed its first case of COVID-19 and about 7,000 affected individuals treated in Combined Military Hospital, Dhaka. It is well established that about 1/4 of the cases were asymptomatic and about 95% patient cured without any complication. Severe acute respiratory illness with fever and respiratory symptoms such as cough and shortness of breath comprise the main clinical presentations. But unusual presentations such as patients without respiratory symptoms or only few very mild symptoms are arising worldwide. From the time of identification to till, multiple clinical symptoms and parameters have been identified by the researchers of various countries and regions regarding the diagnosis and presentation of COVID-19 disease. With that, our aim was to describe the epidemiological, clinical, laboratory, and radiological characteristics, treatment, and outcome of RT-PCR positive COVID-19 patients. It was a descriptive cross-sectional study which conducted from 15th April to 31st May 2020 at Combined Military Hospital, Dhaka. Our study population were RT-PCR positive COVID-19 cases, and we adopted purposive sampling technique. And we took 237 RT-PCR positive cases, and we conducted a face-to-face interview with a pre-tested semi-structured questionnaire and review of the medical record of the patients. Result. The highest number, that is 37, about 37% of the respondents were in the age group 30 to 40 years, which is followed by less than 30 years, that is 30%. The average age of the respondent was 37.6 years with a range of 20 to 67 years. The male were predominant in our study, as well as Muslim were predominant. In regards to the educational qualification, about 58.6% were educated up to secondary level, and 84% were married, and 84.4% were service respondent. About 57% reside in hostel or mess, and 40% were with family. In regards to the smoking history, 45% were smoker and non-smoker equally, and 9% were occasional smoker. About the contact history, 87.8% had contact with a confirmed case of COVID-19 case or positive cases. 44.7% had a history of visiting crowded place in previous 14 days. Very few respondents gave history of contact with the suspected cases, contact with a person coming from abroad, or recent fever. As regards to the chronic illness among the respondents, about 17% had the cardiovascular diseases, 13.5% were endocrine like diabetes mellitus, and 5.5% were suffering from the respiratory diseases. Majority of the patients were presented with about, that is 93.7% presented with fever, which was followed by cough at 62%. Only 1.1% we found asymptomatic. Other symptoms like headache, myalgia, alteration of taste, etc. were also present. In regards to the radiological findings, only 7.2% developed bilateral pneumonia, and 2.5% developed either unilateral pneumonia or ground glass opacity. Rest of the respondents' X-ray were uneventful. About 5.5% respondents showed some lung involvement in HRCT findings, and the lung involvement ranges usually from less than 20% to up to highest 70%. As the disease was an initial phase, a number of treatment modalities were adopted during that time. Majority of the respondents were treated the combination of ivermectin and doxycycline, which was followed by doxycycline and hydroxychloroquine, and others like ivermectin, doxycycline, azithromycin only 5.5%, ivermectin, azithromycin 2.1%. About 1.3% respondent requires low molecular heparin along with other combination drugs. 2.9% respondent received antiviral drugs like favipiravir along with other common combination drugs. As regards to the duration of hospital stay, majority of the respondents in our cases were stayed hospital from 11 to 15 days, that is 49.4%, which was followed by 16 to 20 days, that is 21%. The average duration of hospital stay were 14.6 with a range of 7 to 32 days. And there was no death case in among our respondents. As regards to the biochemical findings, majority of the respondents shows normal biochemical findings. About 17.7% showed neutrophilia, 30% shows positive D-dimer test, 22% showed either sepsis or systemic infection in procalcitonin estimation, 23% showed increased ESR, 28% showed increased ferritin, 28.7% showed positive C-reactive protein, and 21% shows increased lactate dehydrogenase estimation. In our study, many of the clinical presentations, laboratory and radiological findings, treatment and clinical outcome coincides with the other research articles indicating the similarities with the pandemic now ongoing in the world. It will certainly help the clinicians and medical administrators in the armed forces to understand the magnitude of the disease course and take appropriate measures for its prevention. Because of a small sample size and exclusion of critical cases, our study findings may not be generalized in the context of Bangladesh. In this August gathering, I profoundly acknowledged the unique support and sharing resource of Dr. Abu Hassan Muhammad Abdullah and the Commandant, Deputy Commandant Major Farooq and Major Jinnatun Nabi, at the same time participated of the study, and all the in charge of the ward of the CMS Dhaka. Any question?
Thank you very much for your nice, good presentation. And if you have any questions from here. One question from online audience I have is like, how much days you have taken the neutrophil count and what was your follow-up interval?
Pardon, sir?
How much days you have taken the neutrophil count? You have shown the neutrophilia right here?
Sure.
Yeah, so after how many days after admitting to the hospital, a neutrophil count was taken, and what was the follow-up interval of the patient?
Sir, in military settings, sir, anybody who presented with symptoms, then and then we admitted the cases initially. And then we sent the RT-PCR test. Basing on the result of the RT-PCR test, we admitted that case. We developed initially a fever clinic. They were stayed there for about 24 hours in the fever clinic till the positive RT-PCR patient came, result comes. Then we shift them to the isolation ward. And in regards to the follow-up, we usually develop our Shena Shastro Batayon, the call center, one call center, which is operated by the CMS Dhaka. Through that, we usually followed them up regularly.
Yes, so and also there is good information on your presentation that the treatment regimen followed at that time is like now it has changed a lot, you know. So, but the investigations for the D-dimer neutrophilia at that time it was like starting to take up. Now it's like everybody was and after confirming the patient. Positive patients, we are doing the HRT and the D-dimer. But initially it was like few hospitals, they were doing this. And we have, so thank you so this is from the confirmed patients, and this will guide us, our clinician and administration, to develop the clinical management guideline more efficiently. Thank you. Thank you for your nice presentation. So
Thanks.
now I'd like to, any questions? No. Now I'd like to request Dr. Mohammad Jahidur Rahman. He is a APTP Fellow of 6th cohort this year, and his presentation title is Personal Protective Measures with COVID-19 Positive Contacts in Dhaka City, Bangladesh, from March 10 to April 29, 2020. Dr. Jahidur.
Assalamu alaikum and very good morning to all. I am Dr. Mohammad Jahidur Rahman, FETPB Fellow. Welcome to my presentation on personal protective measures with COVID-19 positive contacts in Dhaka City, Bangladesh from March 10 to 29 April 2020. As I mentioned earlier that our study site was in Dhaka City Corporation. The Dhaka City is the capital city of Bangladesh. It is the 11th largest mega city in the world, with a population density of 11,910 persons per kilometer square. The objectives of the study was to identify the risk group among COVID-19 contacts and to observe the use of personal protective measures in COVID-19 positive contacts. Methods. The study was cross-sectional and we collected data over telephone. Our study place was Dhaka City Corporation. We conducted our study from March 10 to April 29, 2020. And our study population were the contacts of COVID-19 positive contacts from this time period in Dhaka City, Bangladesh. World Health Organization case definition of COVID-19 contacts. Any person who comes within 1 meter of COVID-19 confirmed cases for more than 15 minutes for asymptomatic cases 2 days prior onset of symptoms and up to 14 days later. In addition, for asymptomatic cases, 2 days prior date of sample collection. Operational definition. We set a definition of positive contacts. Among the contacts of COVID-19, those who later become real-time RT-PCR positive for COVID-19 were defined as our positive contacts. Our result section. There are 2,182 contacts from 268 COVID-19 confirmed cases. That means 8 contacts per case. The gender distribution was 49.8% were male and 50.1% were female. Median age of the contacts was 30 and interquartile range was 22 to 40. Sorry? Slide share miss হয়ে গেছে না না করছি তো এতক্ষণ তো চললো আবার মিস হয়ে গেছে অটো বের হয়ে গেছে আমি দিচ্ছি Quarantine place of COVID-19 positive contacts in Dhaka city from March 10 to April 29. This table shows that the place of quarantine of the positive contacts, and most those 73% were in home quarantine. This figure shows that the percentage of positive contacts were more in those who were exposed for more than 15 minutes with a COVID-19 confirmed cases, and it was 69%. This figure showing the date of positivity of the positive contacts. From the contacts, we found our first case on 18 March, and the highest number was 39 on 24th April 2020. We have analyzed the data on personal protective measures. We found that 64% of our positive contacts did not use mask while going outside home, and the odds ratio was 5.3, ranging from 3.2 to 8.8 with 95% confidence interval. Regarding social distancing, we found that 82% did not maintain social distancing when exposed to COVID-19 positive cases. Odds ratio of not maintaining social distance was 29.6, ranging from 15.2 to 57.7 with 95% confidence interval. % of our positive contacts was not washed their hands when came from outside. The odds ratio was 9.5, ranging from 5.6 to 16.1 with 95% confidence interval. The final outcome of our positive contacts in Dhaka city, Bangladesh, from March 10 to April 29, we have analyzed total 332 cases outcome, and the death rate was 1.2. We concluded the study with the findings that contacts of working age group, household contacts, and never maintained personal protective measures are more likely to have COVID-19 infection. From these study findings, we recommend that ensure proper education of personal protective measures guidelines may help to reduce COVID-19 infection among the contacts. We also recommend study on knowledge attitude practice, why people are not maintaining personal protective measures during going outside home or during the time of exposure of a COVID-19 patient. We acknowledge Institute of Epidemiology, Disease Control and Research, Director General of Health Service, MISF, DGHS, and FETPB, Bangladesh. And that's all my presentation. Thank you very much for your patience hearing.
Thank you, Dr. Jahid, for your nice presentations. And so, any questions from audience here? I have a question received from the different platforms. It's like one is, how did you selected your population?
During this time period, as I earlier mentioned, from March 10 to April 29, irrespective of any age or sex, we selected all the people who were the contacts of this time of our cases.
Yes. And so how long you follow up your contacts?
For the contacts of COVID-19 cases, we followed them for 14 days. And for the cases, we followed them up to the real-time RT-PCR become negative.
Negative?
Yes.
Okay. And another questions came from, I have not seen the name. Besides the personal protective measures, did you analyze any risk factors?
Besides the personal protective measures, we didn't analyze any other risk factors like diabetes mellitus or hypertension. We focused on the relation between the personal protective measures and with the positivity of the contacts.
So what was the recommendation? One of the recommendation is educate the people about the personal protective equipments, right?
Yes, sir.
or overall health hygiene?
Yes. So we recommended that the proper health education and we also recommended a study on knowledge, attitude, practice of the people, why they are not maintaining the personal protective measures.
One question came is like RT-PCR negative similar signs symptoms to COVID-19. Could they be included in the contacts?
Sorry, sir?
RT-PCR negative, but they have the signs symptoms of COVID-19. Can they be also included in the contacts?
For the contacts, RT-PCR negative, but they have the symptoms of COVID-19.
Yes, yes.
No, sir. We didn't take them as positive contacts.
Why they are not included?
So because within this time period, we also, this was our study population, who they become the positive from RT-PCR, they will be our study population, sir.
Thank you. Yes. So, do you have anyone have any questions? Yeah. Okay, Dr. Mustaq.
As your operational definition of the contract, you have mentioned that those people who came within 1 meter of the positive cases and stayed there without any personal protective equipment, stayed there more than 15 minutes. But in your findings, you again analyzed that most of them were within 1 meter of the positive cases. But you already selected them using these screening criteria. I think still you have to write a paper, full paper after the abstract. It will be better if you analyze the contacts, those who developed symptom afterwards and was positive for COVID, and those contacts who did not develop symptoms or did not become positive. You can compare using that, but distances already you have selected the criteria. Your whole sample is those persons, if I understand rightly, everybody they were within the 1 meter of the positive cases. You can analyze your data in a different way so that you can make a difference between the positive cases and negative cases of the contacts. What are the risk factors between them? It will be a very good paper. Thank you.
Thank you, sir.
So, as we don't have any questions, thank you very much, Dr. Jahid.
Thank you very much.
Now, our next presentation, I would like to invite Dr. Pasim Tarannum Haq, and her presentation's title is COVID-19 in Dhaka City, Bangladesh, Investigation of Index Case, March 2020.
Good morning, everyone. I am Dr. Farsin Tarannum Haq from IEDCR. Today, I am going to present COVID-19 in Dhaka City, Bangladesh, investigation of index case, March 2020. Thank you, respected moderator, for giving me the opportunity to present in this first Bangladesh Congress on Epidemiology and Public Health 2021. Before beginning on first COVID-19 case in Dhaka City, some dates should be marked. On 31st December 2019, the first case of COVID-19 was reported in China. Then on 13 January 2020, the first international COVID-19 case was reported in Thailand. In Bangladesh, the first case was reported by IDCR in the Narayanganj district on 8 March 2020. And finally, the first case of Dhaka city was reported on 14 March 2020. And IDCR immediately deployed a rapid response team for investigation of that case. Objective of our investigation was to investigate the case and conduct contact tracing, and to prevent transmission of the virus by ensuring quarantine of the contacts. Profile of the index case was, the case was 29 years old, male, student in profession, arrived at Dhaka on 1st March 2020 from Düsseldorf, Germany. He had no comorbidities, and he was immediately isolated after detection in a hospital at Dhaka. And on 23rd March, he got negative result. This slide demonstrates that his chronological health condition on the 10th March, he first developed the cough and mild fever during journey to his paternal house in Dohar, Munshiganj. And he didn't record the temperature, but on the next day, his mild sign symptoms were persisted. And antibiotics he took and some home remedies. And on 12th March, and again, he had the mild symptoms, and he took the pyrotics. And then he decided to check up for corona. And on 13 March, he went to Kurmitola General Hospital, a COVID-dedicated hospital in Dhaka, and there we found from the prescription that the temperature was his 99 degree Fahrenheit, and blood pressure was 120 by 80 millimeter of mercury. He had antibiotics, and then he went to IDCR for testing. During case investigation, we did contact tracing simultaneously. The period of contact identification was 6 to 14th March, and the location of investigation was Dhaka and Dohar, Munshiganj. And we defined the contacts as the person who came within 1 meter of COVID-19 case from 6 to 14 March 2020, while caring for, living with, visiting, sharing a healthcare waiting area or room, or having direct contact with infectious secretions of the case. Among identified contacts, and these are the details. The age of the contacts were 2 to 65 years with average age 36 years. In gender, female was predominant, that is 60%, and male was 40%. And in case of type of exposure, direct contact were 40%. And in contact setting, household contacts were 50%. In this table, showing that the identified and missing contacts pointed out according to the date and event. The case when some public gatherings like mosque, wedding, public buses, and village fair. Then we found a very high number of missing contacts, and only 8% contacts were identified. This is the map of Dhaka city, showing the red one is the residence of case and the blue ones are the residence of contacts, where we can see that most of the contacts were in the Rampura, but the region of Dhaka. All identified contacts were monitored from the date of first exposure to case up to the 14th day over telephone daily and sudden visit to their residence on alternate day. Out of 30, 28 were symptom-free, 2 contacts only reported mild cough, and they were tested and got negative result. We investigated at that time when people did not know about the COVID-19 and frightened and they were frightened about the completely new disease. And we faced challenges like false belief regarding the disease spread, and it was difficulties to identify the contacts. Building trust and ensuring quarantine among the contacts were also difficult. And difficulty in the identified contacts in the public gatherings like public transportation areas. And vigilant investigation to avoid unwarranted panic among the public. We concluded our investigation that no new cases reported from the identifying contacts, though majority contacts were missed, though we can say that it was a successful one. In a city like Dhaka, where 23,234 people live in per square kilometer, we recommended to find an innovative way to identify the missing contacts to contain COVID-19 or any other emerging infectious disease. Thank you so much.
Thank you, Dr. Parsim, for your nice presentation, and it was a lot of hell of experiences during the first few cases in the country. And we have few questions from online platforms. Contact tracing is done on 2 days before exposure. Why in this case we have done 4 days before the exposure?
It was at the initial period of pandemic. The WHO's guidance, interim guidance, was developed after the March, I think. It was on the May. And then it was initial period we could identify the contacts 4 days before the exposure to the case.
Yeah, absolutely. And it was like, from any infectious disease outbreak investigations, we did the 4 days contact follow-up at that time. Did you follow the contacts after 14 days?
They had our number, and we told them that if they developed any signs, symptoms, they can call us anytime. And
anyone have? Yes, I know that. So we know this. And anyone have any questions from here? I can add that Parsim was become famous with this case, and this case was presented to Honorable Prime Minister at the time, and Honorable Prime Minister also talked to this case patient after recovering from the disease, and this was different experiences from the outside Dhaka, because the patient was in so many places before confirmation. And he was one of the first few cases. They come to IDCR for testing also. So I hope that this will give us a good insight during the contact tracing and outbreak investigations, and hope that you will come up with a good paper. Thank you, Parsim.
Thank you, sir.
Our next presenter is Pankaj Kumar Naha. He's also a frontline fellow, and he's also a medical officer at IDCR. Before going to that presentations, I'd like to acknowledge that so during these sessions, we have Dr. Omar Qayyum as organizer of the session, and in Zoom we have Dr. Subroto, in Facebook we have Dr. Farooq, and on YouTube Dr. Prince. They are our APTP fellows. Thank you for organizing this session. And Dr. Pankaj, his title is Clinical Features and Home Management of Confirmed COVID Patients in Home Isolation in Dhaka City.
Good morning. Welcome to First Bangladesh Congress on Epidemiology and Public Health 2021. I am Dr. Pankaj Kumar Naha, presenting today's presentation. The title of my presentation is Clinical Feature and Management of Confirmed COVID-19 Patients in Home Isolation in Dhaka City. Before going to presentation, I just sharing the overview of presentation. And these are COVID-19 situation global in Bangladesh, presentation and pathophysiology of COVID-19, categories of COVID-19 according to severity, study objectives and methodology, demography and comorbidities in patient, presenting symptoms at initial interview and persisting symptom on follow-up, treatment modalities followed at home. Now going to main slide. COVID-19, the pandemic, it is caused by severe acute respiratory distress syndrome, coronavirus 2, such as SARS-CoV-2. It is an enveloped single-strand RNA virus. It is genetic infection crossover to human, causing primarily respiratory tract infection. COVID-19 in global scenario. It was initially reported from Wuhan, China in December 2019. World Health Organization declared as pandemic on 11th March 2020. As of 27 March, worldwide total infected case was 126 million and deaths were 2.7 million. COVID-19 in Bangladesh scenario. First reported case on 8 March 2020 and total infected case were 591,806 and death were 8,869. Now presentation and pathophysiology. The spectrum of symptoms of COVID-19 in adult is wide. Ranges from asymptomatic infection to severe respiratory tract symptoms, including severe pneumonia. It may be progressed to acute respiratory distress syndrome and multi-organ dysfunction. Viral neurotropism, endothelial dysfunction, coagulopathy, inflammation, another term is cytokine storm, are possible proposed mechanism for pathophysiology. Now categories of COVID-19 according to severity. We categorize 3 types, mild, severe and critical. Mild is 81%, which characterized by flu-like symptom and mild pneumonia, that is fever, chest pain and cough. And severe pneumonia, severe cases, pneumonia showing the shortness of breath and respiratory rate is more than 30 and oxygen saturation below less than 93%. Critical case was 5%, which is characterized by respiratory failure, septic shock, and or multi-organ dysfunction or multi-organ failure. Our studied COVID-19 patient was mild and remain in home isolation. They follow various treatment options at home, including home-based traditional remedy, symptomatic drugs, and antimicrobial. Despite the major proportion of patients taking management at home, little information is available regarding the treatment modalities followed by COVID-19 patient at home. So our objectives are to describe the clinical presentation of COVID-19 patient in home isolation, to describe the treatment modalities followed by COVID-19 patients during home isolation. The study design was observational cross-sectional study period June to August 2020. Data were collected from 338 COVID-19 patients in home isolation during their contact tracing. Data collection method and instrument. 2 telephonic interviews were conducted in 14 days interval. Using a semi-structured questionnaire, we collected information from the clinical symptoms and treatment modalities followed by them at home. Now, definition of treatment modalities. These are home remedies, including drinking warm beverages, gargling, and taking vapor with warm water. General drugs. These are antipyretics, antihistamine, vitamin C, zinc, calcium, and/or vitamin D, antimicrobial, azithromycin, ivermectin, doxycycline, hydroxychloroquine. Now show the demographic feature in brief. Gender distribution. Male are more sufferer from than female. 58% of male are suffering from COVID-19 and 42% female. Age range from 1 year to 77 years. Mean age 38.81 plus minus 15.6. Regarding comorbidities, 30% of patients had comorbidity and 70% patients had no comorbidity. And these comorbidities are diabetes mellitus, hypertension, asthma, chronic kidney disease. Diabetes mellitus was the most common comorbidity, and which was 63%. Next common comorbidity was hypertension, 48%, asthma and chronic kidney disease were 9%. Now, present symptom at initial interview, we observed 87% patients were symptomatic on initial interview and 13% were absent symptoms. And the presenting symptoms were fever, dry cough, muscle ache, sore throat, runny nose, ageusia, anosmia, breathing difficulty. Fever is the common presenting symptom, which was 91%, dry cough 33%, muscle ache 20%, sore throat 13%, runny nose 12%, ageusia, anosmia, breathing difficulty were 11%. And persisting symptom on follow-up, and these are 88% patients who became asymptomatic and 12% persisted symptom, and 1 was dead. And persisting symptoms were weakness, cough, anxiety, sleepiness, headache, body ache, and loose motion. Weakness was the most common persisting symptom, that was 40%. And regarding treatment modalities, and these are, we observed most of the patients maintained home remedy, and this was 81%, and 66% took general drugs, and 60% took antimicrobial. Regarding general drugs, paracetamol is the most commonly used drugs, and most of them took paracetamol for their fever, joint pain, body ache, and then next common drug zinc 65%, antihistamine 55%, calcium 51%, Montelukast 37%, doxycycline 10%. And regarding antimicrobial drug, we observed 60% of patients took 1 antimicrobial and 24% took more than 1 antimicrobial. More than 1 antimicrobial means patient may use combination of 2 or 3 or 4 antimicrobial. That may be azithromycin, ivermectin, or azithromycin, ivermectin, doxycycline, or azithromycin, ivermectin, doxycycline, and hydroxychloroquine. Among them, antimicrobial, azithromycin was the most commonly used antimicrobial drug, which was 73%. My conclusion, despite COVID-19 being a viral disease, a high proportion of COVID-19 in home isolation took antimicrobial. So our recommendation, we recommended more studies to understand the various treatment modalities used by COVID-19 patients in home isolation, with special attention to irrational use of antimicrobial by COVID-19 patients in home isolation. Thank you.
Thank you, Dr. Nahab, for your nice presentations. And so do we have any questions from audience? Dr. Mustaq Bhai, please.
Hello. Did you ask the patient whether they took the medicine on their own or through some telemedicine prescription from any registered doctor?
During contact tracing, we asked, they collect from, they took drugs according to registered physician or over phone 333.
Everybody, or have you analyzed the data?
Majority of patients this, among some took the drug according to the colleague, collect from drugs from according to the advice of colleague.
You should show that in the table that such percentage of drug was taken from the prescribed registered physician, some for the peers or relatives, some on his or her own. It will be significant findings.
We do not mention this.
If you have data, you can present it later on. Yeah. You have your
And our questionnaire do not mention this data.
I lost the opportunity. Okay, next time. Thank you.
Yeah, Dr. Afzal, please.
Thank you very much for your nice presentation. Thank you. I would like to know, you have classified the cases of COVID-19 in 3 categories. So far I know there are 4 categories of COVID-19 cases: mild, moderate, severe, and critical. So I would like to know why have you done that?
Thank you for a nice question. Actually, for our disease in Chinese CDC, here described this mild, and for our presentation facilities, the mild cases including moderate. Here the mild case, here shows as like as Bangladesh CDC. The mild, here mild case, in case of mild case, here including the moderate case. Just as mild case indicate the flu-like symptom, and moderate case, mild pneumonia, that is fever, cough, with or without chest pain. And here the CDC include mild and moderate, and totally tell the mild case. Both of them tell the mild case. CDC, Chinese CDC.
We are following the Chinese CDC or US CDC?
Chinese CDC.
Okay. But one of my recommendations should be we should follow the national guideline of Bangladesh. In our guideline as well, there are 4 classifications. Yes, I think we should follow them. Thank you.
Yeah, thank you, Dr. Afzal. And so we have a few other questions to you. But before that, one correction. Severe acute respiratory syndrome is not different. So you have to correct the name of the disease first. Your presentation, you had to write that severe acute respiratory distress syndrome. This is not a distress syndrome. This is the universal name of the virus, severe acute respiratory syndrome coronavirus 2. So there is no distress there. And the name of the disease actually is coronavirus disease 19. The name of the virus is SARS-CoV-2. And so I have a few other questions from online. Is home isolation monitored?
We monitored two telephonic interviews by monitoring the patient. First, the positive case initial interview, then 14 days later follow-up.
Yeah, that's for isolation and quarantine follow-up. And so did they maintain it or not?
They maintain.
Hopefully. And how you monitor the isolation? Another question.
Now
this is only the one time we call for the contact tracing and the advice, and after 14 days we call them up that do the test for the negative, or you were okay to go out, right?
Sir, again.
Initially, the protocol was like first day we used to call them for contact tracing and advice, giving them the advice for the home isolation, if home isolation is possible. And then after few days, we call them up how they are feeling and what is the condition of the patient, and it is when they will do the second test for the negative result. But in between, we call them up, or you interviewed in between the during the disease time?
No. In between, we do not call the patient, but patient call us when they are feeling any import, when they are feeling need.
So they call up. This is not then the passive things was happening. And if they need anything, they call you up because we gave them our number in the first interview, right? Yeah. Okay. And another question is, any intervention or treatment done by your team?
No, there is no any intervention.
No intervention was done. And another question is possibility of virus transmission to another person from infected persons, same to according to the severity, like mild, moderate, or severe. I have one advice for you is like, please follow the national guidelines.
Okay.
There are many CDCs in the world. We cannot follow all the CDCs. We can follow the Bangladesh CDC.
Okay.
And we have a national developed national management guideline. They have the categories there. So if you have the data, so please try to synchronize the data with the national guideline. Thank you. Any other question? So we do have an open discussions. If anyone, yeah, Dr. Rabbani? So anyone? So thank you, Dr. Pankaj. Thank you for your good presentation and hard work. So anyone from online want to participate in the discussion?
Just had a question, Dr. Alamgir, for regarding this last presentation and also to the audience as well, to share one point. Shall I?
Yeah, please. Yeah, please. Go on. Go on.
Thank you. So for the presenter, thank you very much for your presentation. I just want to pinpoint one area that in the gender part, gender consideration, that the male-female distribution that you have shown, so the male number and female number varied. And the percentage apparently shows less with the female, but this data figure has got a gender understanding, gender connotation. So I'm sure that you have taken this importantly and also made it very visible in your write-up, because the gender like effect of the COVID is one of the very important issue globally and locally. So this data also revealing that too. And another point is basically to everyone, it's not really a question, because during the COVID time, the treatment, although it is been mostly home-based treatment is been managed mostly. So even in your data, I'm seeing the same thing. So what they have done, they just talk to their friends or the relatives or anybody who is either a registered doctor or a pharmacist, anybody. So then they started taking the medicine, and these are the very high kind of antimicrobial. So the resistance point of view of AMR. So this is very important. So this during the COVID time, the irrational use of antibiotic is one of this. Not only will affect the COVID cases, it will, aftermaths of this irrational use of antibiotic, will be also very high taxing for the clients across Bangladesh. So this issue needs to be highlighted, and the doctors community also needs to be very thoughtful around this issue, because COVID will go after a certain period of time, inshallah. But this antimicrobial, high-handed antimicrobial resistance will make us more difficult life in the future with fighting with other diseases as well. Thank you.
Thank you, Dr. Nazreen. So anyone else wants to make any comment? If no, I thank all the presenters, and we are at the concluding session, concluding this session, and we will back at 11. It's through Dr. Rabbani. Okay.
Thank you so much, sir. It was a very nice and interactive session. A round of applause for all the presenters and the moderator teams. Thank you, everyone. Now we have a short presentation session. I would like to invite Dr. S.M. Alamgir and Dr. Mushtaq Hussain to come up the dais for certificate and crest distribution.
লাইভ হবে না